COVID-19. We cannot be careless. Okay, because as per WHO guidelines, SARS-2 or COVID-19 is a highly contagious disease with high chances of community outbreak and even mortality in persons who are more than 40 years of age. Even younger age are not spared out of it, but it is quite. So I will just quickly say that when you should fear that a patient may or you may have COVID-19 is when you are having fever. Fever and fatigue are the most common findings. Then there is dry cough, sputum in 33% cases. Okay, it may be associated with sore throat, headache, myalgia, chills and rigors. Diarrhea may be there, and most important, if the condition is very severe, it may present to you with dyspnea. So dyspnea with fever and dry cough is the most important. So now coming to the physiotherapy part in the ICU. So mostly traditional chest physiotherapy, which involves removing of the secretions that may not be indicated in COVID-19 patients. Okay, so every patient who is having dry cough, he may not have an indication for chest physiotherapy. Okay, only patients with comorbidities. Comorbidities means patient who is previously having a lot of copious secretions like COPD, bronchiectasis, and if he suspects or he develops COVID-19, then your role comes here. You have to go and treat the patient. So now what are the basic things we should be knowing before we are entering into that ICU setup? Okay, so I will not talk much about, we all know how to do the hand hygiene and PPE protocols. They can be visualized through the AIMS website or the CDC guidelines, Center for Communicable Disease Guidelines. Okay. What I want to emphasize is here is we should be aware of aerosol generating procedures. Okay. What do we mean by aerosol generating procedures? Is that all the procedures in which there are chances of droplet formation. Okay, like when you cough or you sneeze, or when we give a nebulization to the patient. Okay, like if your patient is having dry cough, a doctor may prescribe to give him a bronchodilator or an cough suppressant drug through the nebulization route. Okay, but that is an aerosol generating procedure, and that is a risk here which we cannot do. Okay, so aerosol generating procedures in ICU, it can be intubation, extubation, bronchoscopy. Even if the patient is giving non-invasive ventilation through high flow nasal mask, tracheostomy, or while doing the CPR. Okay, in all these procedures, there can be a chances that the patient may cough or they may spread the infections. Okay, so concept regarding that is that we should not be directly exposing us or restricting our exposure in patients during the aerosol generating procedures. Matlab concept says that if you want to go for nebulization, okay, like if it is really indicated, and if you want to go for nebulization, then go for meter dose inhaler with spacer device. So what is a meter dose inhaler? आपने asthmatic patients में अपन सबने देखा है, we all have seen an asthmatic patient, there is a pump like thing, that is a meter dose inhaler, and if you attach it to a hollow uh, device, that is known as spacer. So now this becomes a closed chamber. Okay, so there are lesser chances of infection. Okay, if your patient is having lung collapse or atelectasis, then spirometry is avoided. We should avoid doing spirometry. Okay, I will tell you why. Because spirometry, if even if you are giving and even if it is required and the patient wants it, then it should be dedicated for that patient. You should not use you cannot use it for the other patients also. And even doing vigorous spirometry, it may damage the lung. Because in COVID-19, it is a type of viral pneumonitis in which there is inflammation of the alveolar-capillary membrane, and it is associated with pulmonary bleeding. So doing more breathing exercise, putting on more efforts may actually damage the lung in the acute conditions. Okay. Why most important is that even if your patient is having COVID-19 and he's having a lot of copious secretions because of comorbidities, previous pathologies. Okay. And if you want to take if you have been prescribed for physiotherapy part, okay, it may be because the doctor wants to prevent ICU related weakness. Okay, so ICU related weaknesses, if the patient is more on mechanical ventilator, is prolongedly immobilized, and the physician fears that you may patient may land up by developing ICU related weakness post op. Yeah, post ventilator removal, the patient may not be able to walk or do his functional activities, and he wants to prevent that. In that cases, exercises may be prescribed, light exercises, functional exercises on the ICU bed, like bridging, sit to stand activities, stand to sit activities. That may be ensured. But before going for that, ensure hemodynamic stability. Ensure, bottom line is, uh, ensure hemodynamic stability. See that your vital parameters are stable. We may in ICU we basically rely on oxygen saturation, pulse oximeter. Okay, so pulse oximeter may not give you the reliable indicator here. Okay, my bottom decline will be while using seeing the pulse oximeter, also see the heart rate of the patient and the respiratory rate of the patient. Okay, so because if there is any kind of respiratory distress or if the heart rate is very high, even if the patient is saying seeing normal pulse oximetry, he may be in respiratory distress. That may be a sign of pulmonary edema or it can be anything. Okay, so we should be careful regarding it. Then before that, also go for checking out blood pressures and hemodynamic parameters of the patient. So if you find that they are stable, then you can go with your physiotherapy session. Okay. If your patient is unstable, then only you have two things, which is suggestive here. That is prone positioning. Okay. COVID-19 patient who is in ICU, he will is more or like a ARDS patient. With active physiotherapy has very little or less role. Okay. Only thing is if you want to help as an uh, supportive staff while taking care of the patient, and you need to do suction, then you should be going for closed inline suctioning. Okay, so you can Google it on the net. Closed inline suction is where the suction catheter is in a plastic wrapper, or it is covered, and you don't need to touch the catheter. Okay, and it is attached to the endotracheal tube only. Okay, so closed inline suctioning will be suggestive here. And if your patient is not on mechanical ventilator, he is on non-invasive ventilation, then you should be looking for that you teach the patient cough etiquettes. So cough etiquettes means they should be coughing in a tissue paper or a gauze piece and not their hands. Okay. Now, this patient should not be coughing like this, closing their mouth, but they should be coughing into a gauze piece or a tissue paper which can be safely disposed and discarded and stuff like that. Okay, and you make sure that you are maintaining yourself away from the blast zone. Blast zones means more than 2 meters of distance. While the patient is doing this cough and huff maneuvers, even if you are assisting the patients while doing coughing and huffing maneuvers, you should be away from that. Protect yourself. So your protection, even if you are not getting a PPE, face barrier, okay, a face mask and a plastic shield barrier, face shield जिसको कहते हैं, that is more or less sufficient from that. And if you follow the other protocols, that you use hand hygiene, change your clothes, and clean your usable instruments which you are using in the ICU, like stethoscope or a vibrator with a 5% solution of what you call it bleach, sodium hypochlorite, uh, that is sufficient to, as per the microbiology guidelines, that is sufficient to remove the bacterial contamination. But again, it is better that if you are entering into the ICU, you don't take your stethoscope. You use the stethoscope which has been or which the other doctors are using there. Okay, that will be beneficial. In this case, COVID-19 patients, pneumonitis case, you may find that on auscultation, you will be able to hear rails. Rails means crepitus-like sounds in the lung fields. They are bilateral. Okay, and we may confuse it with secretion sounds. Okay, that the patient is having lot amount of secretions. Okay, so in this case, I would suggest you that if your patient is on mechanical ventilator, have a look on the plateau pressure and peak inspiratory pressure of the patient. Okay. I will just say what is plateau pressure is the pressure which the ventilator has to push to expand the lung. Its maximum point is peak inspiratory pressure, and plateau pressure is the mean pressure during the inspiratory phase of the ventilatory cycle. Okay. तो अगर किसी पेशेंट का plateau pressure बहुत ज़्यादा बढ़ा हुआ है, okay, means if it is more than 30 centimeters of water, then it is suggestive of pulmonary edema. Okay. So in this case, pulmonary edema, or it is suggestive of fibrosis. In this case, you may get auscultatory crepitus-like sounds, but they not be related to secretions. Okay. And second thing is, crepitus-like sounds related to secretions, they decrease with huffing and puffing maneuvers. They should change in the intensity. But sounds related to pulmonary edema, they change with the change of position. They are positional dependent. Okay. If your patient is on mechanical ventilator, what you can suggest to the or what you can put yourself as a role is prone ventilation. Prone ventilation is very effective. And even I don't have a time here, but I would suggest that you go to the YouTube website and see how the procedure is that the patient is put on the prone in the mechanically ventilated thing. Means patient is intubated, but with a 6-person's team, the patient can be put on a prone position, and then he can be mechanically ventilated. Even his ECG can be taken in the prone position. In ECG, they just needs to be placed on the reciprocal positions, and the patient shows very good results, very good improvement in hypoxemia and clinical status of the patient in prone positioning. So prone positioning is indicated in case of here. And you can do what you can contribute is to do with active assisted exercises, joint range of motion exercise, bed mobility, sit to stand functional activities, because post uh, COVID-19, when the patient will recover, he will surely be suffering from ICU related weakness. Okay, their weakness, it may be because of lung collapse, fibrosis, which has recovered, reduced hypoxia, but more or less it will be due to muscle degeneration. Okay. So this is a point post recovery of the patient. The patients may be sent to their physiotherapy clinics or the hospitalized wards or the hospital PT setups to help the patient to recover with this post ICU or COVID weakness. Okay. Now these patients, they need to be carefully tackled. Okay, carefully tackling means you need to gradually increase their intensity, work more on increasing their aerobic capacity, doing the exercise while doing the pacing or breathing techniques. Okay, and more concentrating on the rate of perceived exertion of the patient. Okay, so this way maybe we may be able to do that. Achha, in the ICU, what we should also not do, like open suctioning is not indicated, nebulization is not indicated, it is not avoided, suggestive. Manual hyperinflation, which we give in case of lung collapse in the ventilated patient, we do an ambu bag and we give manual hyperinflation. It has to be avoided. If your patient is developing lung collapse and you want to improve it by giving manual hyperinflation, what you can use in instead is ventilator based hyperinflation. Means on the mechanical ventilator screen you will find two switches. One is O2 suction and second is inspiratory hold button. Okay, so when you give O2 suction, the ventilator delivers 100% oxygen before suctioning, okay, to the patient. That is advisable. Good. Second is you can put the inspiratory hold button. You can press the inspiratory hold button. So when you press the inspiratory hold button, the ventilator, it inflates the lung and maintains the inspiration. Okay, so it is like a inspiratory hold. It re-expands the collapsed lung. It increases the FRC, and it is more or less a good effect of T. So avoid giving manual hyperinflation through ambu bag, because for ambu bagging also you will have to disconnect the patient from the ventilatory circuit. It increases the chances of infection. If your patient is on mechanical ventilator and he is using mechanical ventilatory circuit. Okay, so make sure that there is an filter attached to it. An HME filter, heat moisture exchanger filter, is attached to it. Okay, I will just see if I can share my screen and I can show you the picture of that filter which is required. And if you all are treating the patient there, you can make sure that you get that. Okay, I hope everyone is getting the thing. So this is an filter, HME filter. Okay, which is suggested that it should be connected to the endotracheal tube and the ventilatory circuit so that the chances of transmission with COVID-19 is avoided. Okay. This is a procedure for safe nebulization of COVID-19 patients. Means the patient is getting nebulizer, okay, but he is being attached to the filter circuit. Okay. Means when he is expiring, first he is using a tight-fitting face mask where there is no leak, and second, when he is expiring that gas, the expired gas is passing through the filter. Uh, Next, I will show, just a minute. Is This is functional activities during mechanical ventilation. Okay, but again, it is, I don't know whether it is suggestive in COVID-19 patients currently or not. But again, you can give it a try. And next, this is a picture showing prone ventilation. Okay, means patient is mechanically ventilated. He is taken care, but he is being ventilated in a prone position. It gives good results in ARDS patients. ARDS patients, it is documented. Other cases, COVID-19, the data has yet to come. Okay, and next thing is about, this is the basic cycle showing inflammation, bed rest mobility, and muscle and nerve injury, which relates to ICU related weakness. Okay, so any patient who will be long term mechanically ventilated. Okay, I would also like to give you a link about this thing. Means I don't know, ये हमारी कंट्री में अभी तक नहीं है, बट ये एक प्रैक्टिकल प्रॉब्लम है कि अगर आप पीपीई किट पहन लेते हो, when you don the PPE kit, it becomes very difficult for you to auscultate the patient. You cannot auscultate the patient because you cannot put your head earbuds into your ears without disrupting your PPE protocol. So maybe in some countries they are developing it that the stethoscope will be linked to your phone. It will be transmitting to the data to the phone, which you can hear through your earbuds, and earbuds you can put inside your PPE kit. So this can be a new innovative form of auscultating the patient in an isolation setup. This can be another form of putting the stethoscope inside your PPE kit. But again, means it depends if you are getting this type of head suit, then only. Okay. Uh, for just this is just a slide to show that what are the current lung protection strategies for patients who are being mechanically ventilated, even for COVID-19. First is they are ventilated on low tidal volume. Second, what I said is we try to maintain low plateau pressure. We give high PEEP so that the lungs are prevented from atelectasis, open lung infection. And we maintain low driving pressures, means peak inspiratory pressure is kept at a lower level. And low driving pressures. And these all are introduced to cumulatively reduce the injurious effects of mechanical ventilation in COVID patients. Okay, because again, pneumonia is a type of inflammation, and when you aggravate that thing, that aggravates a lot. There is so I will share that screen. Okay, so uh, again, just before ending my protocol session, I would like to give my brief, my revise what all I have think, that avoid aerosol generating procedures, means bronchoscopy, non-invasive ventilation. Avoid nebulization, open nebulization. Try to use either spacer device with meter dose inhaler, or if you want to give nebulization, then you should attach an HMA filter. Open suctioning is not avoided. Traditional suctioning, if we disconnect the endotracheal tube, put the suction catheter and do the suction, that is should be avoided. All if you want to do a suction, there should be a procedure for closed inline suction. Okay, or else don't do the suction procedure. Okay. Second is for mechanically ventilated patient, prone positioning is the only beneficial thing which is suggested. Apart from the ventilatory strategies which I just mentioned here, that low tidal volume, low driving pressure. Okay, teach if your patient is not on mechanical ventilation and he is on ICU. Okay, he's on non-invasive ventilation. Teach him cough etiquettes, that they should cough in a tissue paper or a gauze piece. They should not be coughing with their hands covering the mouth, or they should not be coughing into the mask. Okay. Save yourself from the blast zone means keeping yourself 2 meters away from the patient. If your physiotherapy session is required, you can teleconference that, or you can tele deliver that. That is very beneficial so that you avoid the exposure. You can teach it to the nurse if possible, and even if it is required that you go inside, then maintain that safe distance. Avoid manual hyperinflation, because the more you will be inflating the lungs, the more damage it will be causing to the patient's alveoli. Instead of that, use ventilator based hyperinflation or inspiratory hold. Okay, avoid reusable respiratory equipments. Okay, you can go on delivering passive active assisted exercise, functional mobility exercises, and foremost, before starting with the physiotherapy treatment, ensure hemodynamic stability. Look for the saturation, compare it with the heart rate and respiratory rate. A heart rate of 90 with a normal saturation of 90 is a serious thing. If the patient is showing saturation of 90% on a pulse oximeter and his heart rate is going beyond 100, means patient is having. So that's all with my session. I hope it was a little bit useful to you. Okay. Thank you very much.
Thank you so much, sir. If anyone has to ask something,
Yeah, yeah.
any
I'm
queries?
Thank you so much, sir, Rahul sir.
yeah.
And Bhaskar sir, please continue. Your last few slides are not
Yeah.